Welcome to the Paradox PT podcast, where we discuss all things physical therapy, rehabilitation, and clinical practice. I'm your host, Leo Falzon. Today, my co-hosts Brandon Kemper and I discuss whether it's best to focus on pain or on function in rehab. Are those two aims ever mutually exclusive? When should our focus be solely on pain modulation, and when should we focus on function to the exclusion of pain? While neither of us started with fully formed, strong opinions here, I think we were able to make some good headway on these questions, and I definitely came out of the conversation with some new insights. Before we get into the episode, I just wanted to mention that I recorded this from my car, so if by about minute 45 you can hear my teeth chattering and I'm becoming progressively less coherent, it's because I was sitting in a parking lot at a temperature about minus 10 here in Toronto, while Brando was sitting comfortably by the fire, probably sipping some tea. Anyways, without further ado, here is episode 2 of the Paradox PT podcast. Thank you so much for listening. All right, Brando, how's it going, buddy?
I'm doing well. Sitting here on a snowy Saturday morning on the West Coast. You can't complain. I got my wood stove going. It's a beautiful sight out there. How about you?
I'm good, man. I'm feeling better. Recovered from the COVID, so that's a positive.
That is so crazy. So, you and I recorded our first podcast. Basically, what would you say? The day of symptom onset for you?
It was the day before, I think. Or no. It was the day of symptom onset. Yeah, it was that evening that I came down with a little bit of a sore throat. So somehow we were like, 4 feet away from each other, talking into the same laptop, and you never came down with symptoms?
Not a single one. You know what was crazy is we did the podcast, but we also did all that manual therapy work, and I remember laying on the bench while you were showing me some cervical spine techniques, and I remember like a little bit of spit came from your mouth and landed on my upper lip, and like I didn't say anything, but I closed my mouth and just like didn't want to breathe for a second. You know what I mean? I was thinking, you know what? Like, it's so funny too. Because, you travel across the country and, because we're such good friends, you think, whatever, you let your guard down a bit. And yeah, man. So as soon as you got COVID, I thought, that's it. I'm getting it, for sure.
I figured as well. I mean, the night prior, I blew out all the birthday candles, right? And then it was like, you have a piece of cake, you have a piece of cake, you have a piece of cake.
Oh, I forgot about the birthday candles.
Yeah, God knows how, the whole crew didn't get it, but it is what it is, right?
It's crazy. So none of your folks, like none of my family got it?
Yeah, no, my family was totally fine. It was just Laura, just me and Laura.
Oh, that's just incredible,
Yeah.
But feeling good since?
Feeling good. Yeah, it was about 36 hours of flu-like symptoms, and then I was on the road to recovery and did my isolation, and I've been back to work. Got back in the clinic on Wednesday, and yeah, here we are on Saturday now, taking a bit of time to chat and yeah. How was your kind of reintroduction to the clinic after Christmas? Been busy?
Yeah, over the holidays I was, being the new PT, I was one of the only ones around in Port. The rest of the physios took some time off, so I had a really, really busy week. But, comparing both my clinics in two kind of different locations, or two different communities, it seems like there's a pretty good lull period, like, through Christmas, through the holidays, obviously with all the snow that we're getting on the West Coast, and then, with the new and improved Omicron. Yeah, it seems like there's a bit of a dip in the demand. But what about you guys back east?
Mm-hmm. Yeah, no, ups and downs. I mean, I would say January typically is quieter because people try to burn through their benefits in December. Just the reality of it. And then, we're pretty heavily locked down right now. So that can be a good thing, but it can be a bad thing, because it's a good thing for business for us because people have really nothing else to do, so they don't miss their physio appointments. But at the same time, there are a lot of people that are very hesitant, and with the cases being where they're at, a lot of people are just hunkering down and staying in. So Yeah, it's ups and downs of private practice, man.
No, totally true. Totally true. It's so crazy too because you work really hard, maybe 1 or 2 days a week, and then you have this lull, and the lull kind of feels nice. Kind of recover from the busier days of the earlier week. But when you're not constantly seeing patients, it reflects quite a bit on the whole paycheck, doesn't it?
Oh, 100%. Yeah, you kind of have to budget for months that are slow, you know? You
Totally.
have certain months that are really, really good, and then you're like, okay, like this is my annual income based on that calculation, and then it's like, okay, maybe not.
Oh, it's so true. That's grounds for another podcast. Is how the heck do you keep track of all your billing as a subcontractor? Because it is not an easy feat, you know.
Yeah, yeah, honestly, that would be a good podcast to do, to go just hear. Honestly, I'd love to hear your perspective on it.
So
But today, I guess the plan was to chat about whether to focus on pain or function in rehab. When to focus on one to the exclusion of the other, when focusing on one detracts from the other. Are they two things that you can kind of work on simultaneously? And yeah, I just kind of wanted to get your thoughts on whether you take a very pain focused approach to rehab or a very function focused approach. And yeah, I figured it would make for some interesting conversations. So what do you think, Bran? Where
absolutely,
do you gonna go with it?
absolutely. Well, why don't I start off by even just juxtaposing the two clinics that I'm working for here. One of the clinics is really more kind of you want to say like geriatric slash longevity type care. And their whole business model is to take away somebody's pain. Like that's why they're in business. And the clinic owner is very, very adamant on the whole reason that the client is coming to see you is because they are in pain and they no longer want to be in pain. And it kind of sets this tone that if you can't change their pain or if you can't improve their pain in one session, that you're somehow failing, failing not only the client but the business. And it's breeding this sort of anxiety, like this performance type anxiety for me that I think that is just one unfair and two just not possible to solve, and not possible to solve from a physio standpoint, but even any standpoint and any healthcare professional can offer, especially after one session. Um, so juxtapose
Hmm.
that to my clinic in town here, where that's not the sole goal is to change your pain, right? Is it's overall improvement, right? Um, and I think
Hmm.
that from this perspective, it seems to me that we shouldn't be in the business solely of removing people's pain because a lot of the time it's not possible. I would say maybe, again, maybe not most of the time, but in my limited experience so far, it is not the most easy feat to try to conquer. And I think that if you were to go down that whole aspect of we have to change somebody's pain, that you're just going to get burnt out and frustrated yourself as a clinician. And I think you're going to just disappoint your client by setting those expectations early on.
Yeah, yeah, no, I can totally relate to the feeling of anxiety around getting somebody out of pain in like session one, session two, and if it doesn't move in that direction immediately, kind of having some self doubt creep in, like, am I doing the right things? Do I have the right diagnosis? Just what am I doing here? And yeah, it's tricky, right? Because pain is one of those really multidimensional phenomena that, I mean, it's one of the most complex things that we have as part of the human experience, and it can both be influenced by so many different things, um, and so it's kind of like nothing works but everything works when it comes to pain. When you look at the like a lot of the data we have, it doesn't show like that we have a silver bullet for pain relief. But having said that, pain can be influenced by so many different factors that we have a lot of avenues to play with. Like one of my favorite studies, which shows kind of the plasticity of pain. I don't know if you heard about this one. It was like a Lorimer Moseley study, who's fantastic, by the way. And they put a cold object on people's arm, and half the group are basically looking at a I think it was they're shown a red light, and the other half of the group is shown a blue light. And the people who see the red light rate the the stimulus as twice as painful as those who see the blue light. And just to illustrate that pain can be so powerfully influenced by our beliefs and our expectations, and it's slippery and it's hard to get a handle on. And I think all that's to say that if you make your practice solely focused on pain, then it's a little bit harder to hang your hat on your interventions based on the evidence. Whereas when I focus on function, I know that I can help somebody walk up the stairs. You know what I mean? Whereas if I just have them on their back and doing manual therapy, like maybe I can get their pain to go away, maybe I can't. But anyways, I'm getting too far into the weeds here. But what do you think about that?
No, absolutely. And I like how you said even just the power of your psychology with pain, right? Like the whole notion if you see a red light or a blue light, and it kind of ties into like what are we selling here? Like, are we selling what is true, or are we selling something that I can make you believe something that something isn't true? And it's kind of like the pharmaceutical companies, right? Like how they make antidepressants blue and not red. It's like this trickery on our minds, and maybe that's an important part of rehab or important part of medicine. But I think to act ethically, you should focus on things that, one, you can record, and two, are true. And there's nothing more real than somebody who can't ambulate the stairs and then over the course of a week and a half can, and they come back to you and say, holy smokes, like my mobility has improved tenfold, thank you. And that kind of brings me into this whole umbrella of, I was trying to sort through this, was why should we focus on function, and when should we focus on function? And I think an umbrella term is we should focus more on function than pain when we're dealing with any type of chronic condition. I'll let you have your way with that. What do you think?
Yeah, no, I think that's really good. One of the things that came to mind when you were talking was that, like, a lot of the painful conditions we treat have a favorable natural history. And whether or not we do manual therapy or exercise or wave gems or say prayers or whatever it is, a lot of the times pain will get better independent of what we do. And so the question for me then is, where does my client come out after the intervention? Do they come out more fragile and overprotecting the area and feeling like they're not confident to move? And that's where you move into that kind of chronic pain, where it becomes a sort of more of an overprotection issue as opposed to an acute tissue damage problem. Or if we try to keep them robust from day one and get them moving and teach them that they're not fragile, maybe they come out of that, like that natural history where the pain just goes away, but they're a lot stronger. And they haven't had this kind of secondary deconditioning that might have happened if we just kind of treated them with passive techniques.
Totally agree. And that kind of comes back to my initial point of how do you build your business model in physio, is like, if you're focused around removing people's pain, what type of physio are you going to offer these people? Right? Like, are you going to get them loading? Are you going to get them moving? Are you going to get them pushing themselves? Are you going to get them in a state of, I need to protect this, or in a state of, I need to adapt to this? And I think that when you solely deal with pain, you can't push your client to overcome. You can only play within the confounds of what they find painful. And what everybody finds painful is different, right? So it kind of breeds this sort of ambiguity of, okay, like my last client said that was too painful to do, but they did it anyway. And this client says, well, it's too painful to do, but really this new client is showing half or experiencing half the level of pain as my prior client, but for whatever reason my prior client is willing to do things, well, this one isn't, right? So it's like there's no way to track it, for one. And then for two, like, if you can do it and it's not going to hurt you, but it's a little bit painful, you probably should do it. Obviously, there's conditions that exclude that, but I haven't come across very many. I feel like people are
Well, when sorry, just to kind of cut you off there, when would you say you wouldn't push into any pain with exercise? Like, are there any clearly defined kind of boundaries there?
So, there's conditions that have come into, even just in my last few weeks of practice. One, some rheumatological type conditions where I think that pushing through pain during like a flare-up, let's say, is probably ill-advised, because the flare hopefully will pass, and then we can get to moving then. And I can juxtapose it with an easier condition like osteoarthritis, right? When you have just a painful knee that you just don't feel like bending. And like, I think those, although both are conditions of a joint, are two different situations where pain should guide you and pain shouldn't guide you.
Yeah, I agree. And I would add to that, Radicular pain, in my experience, you don't really get great results by pushing into pain. You just flare people up, you know. And maybe the other situations would be like a, kind of a post-op, really acute situation. But yeah, no, I totally agree. I cut you off there though, and where exactly were you headed with that last point?
I got invested into this new part of the conversation, so I regretfully don't know.
Okay, well, hold on. Let me try to bring us back on track. So like we were kind of talking about in chronic conditions. That's when maybe you'd focus more on function, because at that point, like, pain maybe doesn't equate as directly with tissue damage. Like, do we agree with that?
Oh, 100%. 100%. I agree with that. I think that, like that whole notion that hurt doesn't always have to equal harm. And it kind of brings us into that whole fear avoidance model, right? Like if we have an acute injury that doesn't resolve and all we do is protect it and immobilize it and are fearful of it, then we kind of enter into this vicious negative feedback loop, or positive feedback loop rather, of the fact that when it hurts that I shouldn't move it because I'm doing further damage. And I think
Yeah.
that's only going to make us worse off. I think we're going to start removing the things that we love doing. We're not going to engage in any sort of activity that can cause it grief. And even if those activities are something as simple as getting up and cooking breakfast, and I think we just get far too reliant on other people at that stage, and when we just create this narrative for ourselves that we're broken and there's nothing that we can do about it. And I think that's just such a poor way to look at the world.
Yeah, 100%. So, like, as much as it's hard to have a recipe for treating pain, I could pretty much give you a recipe for developing chronic pain. So, you have an acute injury, you overprotect that injury, and you never load it. You avoid all the activities that, the pain is kind of keeping you from, and then you become weaker. And then you lose capacity within the joints and the muscles and the soft tissues in that area. Um, and then you develop, like you said, this sort of, like, what they call kinesiophobia. There's fear of movement. And we know that, like, I'd say probably the best modern conceptualization of pain is as a threat detection mechanism. So our body will put pain somewhere when we don't feel safe. And so if we don't, like, if we kind of go into that cycle of avoiding, and we never expose ourselves into those painful situations, we can develop that sort of threat sensitivity very rapidly, and it can get heightened. And so yeah, I completely agree with you. And I think that's how you develop chronic pain. And I think focusing on function in rehab is really us trying to prevent some of those cases that are acute from becoming chronic. Because I'll tell you, if you demonize certain movements and positions, full stop. Like, let's say somebody's sensitive to lumbar flexion, and you teach them to hip hinge, which is great. Like, and it's an avoidance strategy, but you don't couch that with the narrative that, listen, once you're out of this acute sensitive period, like, lumbar flexion's fine.
Mm-hmm.
Then that person develops a total pathological fear of movement. And that's when they can become a chronic pain patient, where they're so rigid and their back muscles are always in spasm because they're always worried about, like, the positioning of, not being in the wrong posture. And so, yeah, yeah. I'll pass it back to you there.
No, totally, and I think that, and coming back to my point too of this whole business model of not selling to your clients that we're only here to take you out of pain, is we were talking about a little bit what type of physio are you going to receive. And especially in my retirement community that I'm serving, is a lot of the treatment that the clinic wants them to receive are treatments that, one, don't have great research for, and two, just kind of make you temporarily feel nice. And I think that if you just temporarily want to feel nice, then you shouldn't spend money on physiotherapy, right? You could spend money doing something that is far more enjoyable. So it creates this clinic that is structured solely around providing nice treatment, not efficacious treatment. And
Yeah.
when you see that, it's like it just, especially being early on in your career, it really hurts the heart. Um, and then, it's sometimes justified in this notion that, people usually get better just with time anyhow. But that's no way to reconcile it. Um,
Well, and are you just making them more fragile on the other end of it? And do they feel like dependent on your passive intervention, which maybe they might not even need anyways.
No, absolutely true. Absolutely true. So I think that
Hmm.
with that, but you do have some times where you don't need to push through the pain, right? Like, and I think this maybe relates to the different types of pain that we have. Like, as we were kind of saying earlier on, there's this more acute pain, this chronic pain. There's, you were saying, radicular and referred type pains, but there's also like emotional pain, and like psychologically generated pain. And like I've done a little bit of light reading around like the whole enteric nervous system and the connection with that, or even just like an amygdala response, or people who suffer from mental illness, anxiety, and depression, and having what is it, like twice the likelihood of developing chronic pain. And
Yeah.
you think like maybe some of those types of people who don't have much resilience in their life, or who suffer from these types of comorbidities, maybe they don't just need to be loaded, right? Like maybe they don't need to just push through this pain. Maybe they need some of the smoother, you know, not I wouldn't say passive, but less invasive type physical therapies.
Well, or I mean, I'll maybe push back on that a little bit and say maybe they need to address their pain through a different avenue. Like maybe if we think of the analogy of the cup, and if when the cup overflows, you get pain and injury. Like maybe you've got their loading as one kind of layer of the cup, but then you've got the anxiety, you've got a toxic relationship, you've got poor sleep, you've got kind of an inflammatory diet, and all these factors, stress at work. So like maybe sometimes we put too much pressure on ourselves to be like the arbiter of recovery, when really maybe a person would benefit more from just spending more time with family, and engaging in some meaningful activities. Do you know what I mean? Where like maybe it's not always on us to get somebody out of pain, and like maybe we can have some impacts on those psychosocial factors kind of indirectly by giving somebody a positive experience with movement, and a positive kind of that unconditional positivity as a clinician. But maybe sometimes those kind of peripheral avenues to address pain are actually a better way to go about it, or are the mediators of recovery for certain people.
Absolutely, absolutely. And I think I have a few clients on my caseload right now that are just, the psychological component of their pain is just so overwhelming that exercise prescription, I don't think, is going to be the kind of the bridge of the recovery. I don't think that's going to be enough, although it would be good for them. I feel like there is a subset of the population who, for whatever reason, just can't commit to the exercises that probably would be good for them. So I feel like in an effort not to lose them, we need to be a little bit more open-minded as therapists. And maybe this is where modalities or manual therapy, or even just the notion of pain education science, or just communicating with somebody, like letting them come in for a session, you moving their joints for them while you build rapport, talk to them, listen to them, validate them. Maybe that's okay for a session, and I think that what I'm doing right now is I'm having a hard time having one foot in each sort of camp, and I'm feeling like I need to choose one. We listen to people like Adam Meekins, and I watch his podcast a fair bit, and I think, wow, that's the physio that I need to be, because that's one of the most science-based type physios to be, and I want to be science-based, and then you think, well, maybe that's not the only solution, right? Like maybe there's some sort of middle ground that I can come to, where, and with relation to this podcast, that we should focus both on pain and on function. And maybe that somewhere in the middle is an okay place to be into practice.
Yeah, no, I totally agree. Like I'm not a hardliner on passive interventions that are, clients on the table, you're doing some manual work. Like I think sometimes somebody's so wound up from like a nervous system perspective that they just need to lie down and like breathe, and maybe you do some manual work in conjunction with that, and it just kind of winds down that sensitivity. But I totally agree with you. Like when you're always so focused on like what does the evidence say, like about like what do I have an RCT to tell me that this manual therapy technique is like the best approach, like so like it's it kind of hamstrings you. Like it makes it hard to practice, because you get these people that just, they're not, you kind of have to meet them where they're at.
Totally.
And sometimes maybe that means for a session or two, doing some things that are more just like down regulating the nervous system and just calming things down. But I think the key thing is that you eventually try to build them back up. You know, you don't just build kind of a dependency model of treatment where you need to see me 3 times a week for this manual therapy technique for until the end of time. You know?
Totally true. Totally true. And maybe that's just a good framework to root your practice in is you know, it's okay to take time with people. It's okay not to deliver the most evidence-based type practice for said condition all the time, because no two people are alike, right? And I think that instead of beating ourselves up over the fact that, well, you know, I'm not getting this person hip hinging and deadlifting by, you know, session 2, I'm not doing my job as a physio, like maybe we shouldn't be so hard on ourselves about that, you know. And maybe sometimes the patient reporting to you that, oh, you know, like, although I'm not doing as many exercises as I want to, and I feel better, like I feel a bit better, I feel good just coming in and talking to you. You know, like I last week I have this one patient, and again, she suffers from like end stage OA in like both of her knees, and it was, you know, just totally immobilized, walking with a gait aid, and the first 2 sessions, all we could do was get situated on a new step bike, and she could do half revolutions of the pedals, and just talk to me for 20 minutes, and then it would take probably 15 minutes just to get her on and off the darn bike. And I was thinking, like, I feel like I'm kind of failing you here, you know, but like she keep coming back in, and we kept doing more and more, and she now is like, we've improved her range, like from probably like 40% more range in both knees. She's walking without a gait aid, like she's going to the pool, like all these amazing things that at the very start, I was thinking to myself, I'm kind of failing you as a physio. And now she's coming to me thinking like, hey, like I have this orthopedic follow-up consult for my total knee replacement, and I want you to write a report for me because I'm thinking of not getting the surgery now. And I think, wow, what a bloody win that was. And it all started with just 20 minutes doing half cycles on a recumbent bike. And I thought, wow, that's amazing, right? But in the moment, I was beating myself up, thinking like, crying out loud, I got nothing for this lady. She's just wasting her time and money to come and see me and talk to me on a bike for 20 minutes.
Yeah, it's I mean, that's fantastic, and I think it's such a beautiful illustration of the fact that we got to play the long game, and a big part of that is just building the relationship with the client, and you know, building some trust. And it doesn't always look like you think it's gonna look for whatever given condition that you're treating. But yeah, over time, like if you build like there's a reason that our profs would always bang on about therapeutic alliance, right? That buzzword.
Yeah.
It makes a hell of a difference. Like if you can get somebody to trust you and to have a relationship with you where there is that unconditional positivity, and like the difference that can have in somebody's life, independent of what you do physically, even if the first few sessions are just really, really slow, right? I had a guy last week who came in post-surgery, and he just needed to tell his story. So the first session, we literally chatted for 45 minutes. I spent a bit of extra time with him. I assessed his range of motion, gave him one simple intervention to go home with. And to me, that's a more successful session than if I had rushed him, not listened to him, and given him like 5 exercises to do. You know what I mean? Because it's going to be a long recovery anyways. So like building that alliance is just, it's step one. I think if you don't have that foundation, you know, you don't really have a good place to move from.
Oh, it is so true. And at the end of the day, like physios being like this primary healthcare providers, like we're in a bit of this service and people industry, right? Like we're frontline workers who just interact with people on their day to day. And I think the easier time you have building rapport and building a relationship with somebody, the better of a physio you're going to be. Some of the nicest feedback I've ever received isn't on, it really has nothing to do with my abilities as a physical therapist, but my abilities is to just connect with another human being. And I don't know if that's good or bad, but people say that within the first 2 weeks, I had one guy say that I what the heck did he say? Words like miracle worker, and I'm thinking like my abilities as a physio are so below, I think, what they need to be. But why do you like me? Like, why do you think that whatever we're doing here is working? And I think that it's just because that he trusts me, and we've built this relationship predicated on mutual respect, opposed to some sort of a power differential between clinician and patient. Like I think that the more you can just treat people as human beings and be there for them, like as you would be for your spouse or partner, the better of a
Hmm.
clinician that you're going to be. And brings it back to a saying that I really follow is like, they're not going to care what you know unless they know how much you care. If there's one thing that I really strive to do, especially after an initial assessment, is to just not make them, but enable them to understand that I care for them and that I'm in their corner.
Yeah, yeah, no, that's beautifully put. Having played a role in mentoring some students over the past year, that was one thing that I constantly harped on was treat them as a human first. Like when you see on your schedule, oh, lateral epicondylalgia, or I've got sciatica or whatever it is, that immediately the student would spend time researching that condition, and it's obviously so important. But then they'd get in the assessment and they would treat the patient like this, like a case in a textbook. And it's worth spending the time to ask them, like, get to know their life, like what do they like to do in their life, get to know the names of their kids, build an actual relationship with them, and then they'll trust your advice, right? But if you just come in without building that rapport and you say you need to do X, Y, and Z, and I just I feel like it doesn't work as well. So yeah, I completely agree with you, Brando. It's all about treating them as a human first.
Absolutely, absolutely. Um, why don't we circle back to a little bit of some of the conditions where I think that pain does. There's one I was thinking really really hard, and I actually proposed this in physio school, and people thought that it was absolutely ridiculous. But I feel like there's one condition, um, and it's not just one pathology. It's more of a sub, again, an umbrella term for multiple conditions that I think that pain doesn't really matter at all when you're working with patients as a physical therapist. And again, I'm not adamant on this, and I'm totally open to change. But in my estimation so far, I feel like when you work with palliative patients, I feel like pain shouldn't even really be much in the conversation.
Mm.
And people think that's a bit crazy, but if you're down to, let's say, your last month or your last few weeks of life, and a lot in the hospital, I worked with a fair bit of palliative patients, and you had this conversation with them, and they're just in so much pain, and their pain. There's nothing that you can really do to change it, right? They're on the highest dose of morphine or fentanyl or whatever they're taking. Um, so there's nothing you can do as a physio to change their pain, really. Um, but they have goals in mind, right? There's things that they want to do, and the goals don't have to be anything crazy. And one patient simply just wanted to be able to sit up in bed and have like a breakfast with their family. And again, weeks to live, right? So you think, well, I know it's going to hurt if we try to do a little bit of abdominal work or leg raises or anything to just like develop your even like your erector
Yeah.
spinae, right? Like it's going to be a little bit painful. But if we just practice this and find positions that you can erect yourself in to have a sit down meal with your family, that's that's probably the most important thing to focus on. And is it going to hurt?
Yeah.
Yeah, it's going to hurt. Yeah, but does it matter in that moment? I don't. Again, I'm open to change, but in this moment, I don't quite think so.
Yeah, yeah, no, I love that. And I think sometimes, like, that's a nice way to frame it. Even if pain doesn't change at all and it's still there, if we're getting if we're getting people back to doing what they love, that's a win. Like, even if they're still in pain. You know what I mean? Because they typically will have come to you not really just because they're in pain, but because the pain's impeding their life in some way. Like, it's getting in the way of some activity that they want to do. And even if the pain is still present, and it's not fully gone away, if we can get them to the point where they're able to cope with it and do what they love to do, like that's beautiful. That's what it's all about, right? And I look at occupational therapy as a really like a shining light here, where like they just focus on function. It's like I don't know where in physiotherapy we got so obsessed with just modulating pain, but like OTs, when you're in the hospital, it's all about the daily, like ADLs, activities of daily living. Like,
Yep.
how do we train somebody to be better prepared for their life, and shifting from preparation to preparation from kind of just a pain sensitivity framework is like that was the shift for me that I think allowed me to it really helped me avoid burnout in practice, because yeah, I was getting really caught up in, if their pain score hasn't gone down by 3 points this week, like gonna have to reevaluate everything. But if you frame it as, oh no, your pain's the same this week, but you went for a 6K walk instead of a 2K walk with the same amount of pain, like that's progress.
Amen. And it's objective, like, and it's the same for everybody, right? Like six, it doesn't have to be 6 kilometers, but doubling the amount of kilometers you walk is the same for everybody, right? No matter who's walking. But when you say like my pain was reduced from an 8 to a 6, everyone's interpretation of that scale is different, right? And it's funny because some of the people that I have in clinic, the first thing they'll tell me is, "Oh, I have the biggest pain threshold that you ever did see." And a lot of the times, the
Yeah.
people who tell me that are often the most reluctant to move and to tap into pain. So, how do you feel
Yeah.
about the pain scale? Do you feel like it's do you think that it's well standardized and reliable?
No.
No.
In short, I would say it can help to give people like a frame of reference and show them like what 5 is. Like sometimes I'll say like 5 would be about a bee sting. Because people like oh, my pain's a 7 or an 8, but they walk in, they have no grimace on their face. Like I don't think they really understand what a 10 is. You know what I mean?
Mhm.
So yeah, I don't. I mean, I'll use it for people who, if I think we have a good standardized understanding of what it is. But I've moved away from even using it that much. Really, like I feel like you can kind of get a sense just based on like physically examining somebody of how much pain they're in. Like obviously, like there's some people that can really hold a poker face,
Mhm.
um, but often the numbers are super misleading.
Mhm.
What do you do in practice?
I when I first started, and again, I'm only on week 6 now, but my first week, I was becoming exhausted because that was no matter what somebody was doing, I was always checking in, like, is this causing you pain? Pain, like questioning, like, are you in pain? Are you in pain today? How's your pain? And it just gets so tiring, right? Because a lot of these people have been in pain for a very, very long time, and like, what do I expect after like seeing them for a week? Like, do I expect that they're going to be out of it? So I was almost disappointed when they said, no, I still have pain. So I slowly
Yeah.
stepped away from that, and I only have a few examples, and I think that you mentioned like the whole sort of like radicular pain. I feel like
Yeah.
inquiring about that is important. And I think that maybe just from if it's centralizing or peripheralizing, like I feel like that's an
Yes.
important time to ask that question. Um,
Yeah. I agree. I think it depends on the condition and the patient. If it's kind of this like, oh, chronic neck office worker neck pain, it's not, it's not that big of a deal. But if it's like raging radicular pain, like if the intensity is decreased or the location has decreased, we're starting to centralize. Like that's in info that's critical to understand. And obviously it's, I mean, for students that are listening, like it is critical to take like a good account of where it's at throughout the day. And we're not saying to completely just shove like the pain numeric rating scale out of your practice. But I think it's probably, maybe what we're getting at is that it's you don't need to like it's not always reliable,
mhm.
maybe, is one point. And then the other point is that focusing on that to the exclusion of focusing on other outcomes is probably not good.
It's so true. And I had this funny thought that the pain in like the 21st century isn't like true pain. Almost like hunger in this day and age isn't the same as actually being hungry. Like we don't even really know what hunger is because food is so bloody abundant to us. Like maybe pain's
Yeah.
the same. Like we focus on these little aches and pains because our health is we're in such good health and the world is in such good order that we can complain about. Again, I find it funny to say, but like if a runner on her 44th kilometer of her marathon says she's developing 2 of 10 medial knee pain and comes to see you to try to change that, it's like that's crazy to me. You know what I mean? Like I feel like we should normalize pain, right? Like I feel like most people have some pain on the day to day, and I feel like that should be okay. Just like being hungry
Yeah.
is okay.
Yeah, 100%. And I think you can see like different types of clients. Some people who have a really mature perspective on it, where they're like, oh yeah, like I'm feeling a little bit of pain, but I'm fine to keep going. And then you have other people who, like, at the first sensation of any sort of discomfort, they pull back from doing whatever it is they're doing. And I think that's a really key distinction to make when we're talking about when to poke into pain versus when not to, is splitting your, like, trying to determine whether your client is what they call in the research like an endurance coper or an avoidance coper. Are those terms that you kind of have in your lexicon?
Yeah, and that exactly goes into that whole fear avoidance model that I was mentioning earlier. Yes.
Yeah, so if somebody, I have plenty of clients who, if I tell them to do exercises, they will do them. They will push through that pain. And then they're flared up the next week. And then I got to, okay, this person's an endurance coper. I got to be a lot clearer on, the pain thresholds that are acceptable here. Whereas there are certain people who are just, yeah, like I said, they run at the first feeling they get, like they can't handle it. So I think that's a helpful framework to have when you're deciding whether to expose or avoid.
No, absolutely. And while you were talking about that, I just Googled that figure, and I think the figures, there's a reference here for, I think it's Weidman et al. In 2013, and yeah, he put this fear avoidance model up that, like you said, you have this injury, and this is me just reading off of this model. So you have injury, and then you have this pain experience because of it, and then you kind of have that fork in the road, right? You have the people who don't confront it with fear, who then confront it and then recover from it, or you have people who catastrophize about it, have that pain-related fear, and then avoid it, and then they have this disuse, depression, disability, and then just that full circle of back in pain, catastrophize some more, avoid it some more, be more disabled, be more depressed over it, and it just keeps going.
Yeah, no, 100%. Yeah, and that's I think why it's, man, like, you got to focus on function from day one. Like, you want to avoid that cycle.
Totally.
And one of the things that popped into my mind as you were talking is like, exercise can be an analgesic too. So it's not like focusing on pain versus focusing on function are these two. I guess what I'm trying to say is that you can focus on somebody's function and impact their pain at the same time. You know what I mean?
Totally.
We know that there's central mechanisms in terms of like endogenous opioid release from the, at the level of the cortical structures, kind of descending inhibition. You have at the level of the spinal cord, this kind of modulation of sensitivity and like pain thresholds, and then you have at the periphery, like the actual tissue. So there's all these, like, an exercise can affect any one of those different areas. So yeah, I would say, man, it's when we talk about getting somebody out of acute pain and modifying symptoms, I can do that through movement, like through a breathing drill, or through getting like if somebody has knee pain, I have this hamstring bridge drill I really like, where I get them co-contracting their calf and their hamstring by their forefoots on like a foam roller. And often, like, I'll just get them to do 20 seconds of that, and they stand up and they're like, oh, my knee doesn't hurt anymore. Like, okay, well, we didn't massage you, we didn't put needles into you, we didn't do anything hands-on. Like, all that we did there was show your nervous system that you're safe by kind of giving you some support in and around the joint. So I think often, just like, that's why my bias is to focus on function, and that's why my bias as a therapist is to focus on movement. Yeah. And active stuff, is because it can kill two birds with one stone, right?
Totally, and I think that reconciles this, basically those two different, what do you call it? At the start we kind of make it mutually exclusive, right? We say pain or function.
Yeah,
but
that's the term I was looking for.
Totally, and like, I think it, like, referred to as like exercise-induced hypoalgesia, right? Like, that's the whole notion of it, and there's many ways of getting there, right? Like aerobic exercise, resistance training. So multiple ways to that same end, but while focusing on that function, while getting them to exercise, you kill two birds with one stone, right? And you combat the pain and you improve the function. I think it's a damn good win-win.
Yeah, no, I'm 100% with you.
What do you think of the whole notion that pain is just in the brain?
Well, it's not just in the brain. So we know that pain is an output from it's rather than an input, right? So that's a big phase shift that I think like a lot of lay people do have the conception that pain is a representation of tissue damage. If my back hurts, something is injured in my back. But we know from the literature that pain is more of a it reflects more the perception of threat, really. And you can make like Lorimer Moseley's experiments honestly are like the best way of looking into this. He has a great TED talk, which is really worth listening to, where he just goes through all these studies where they can give people like a VR headset or sorry not a, yeah like they give people these goggles which make them look at themselves kind of from the outside, and then they touch the person's arm, and they can get the person to point to where it hurts, but they point on the other, like in the middle of the room, like not on their arm. You know what I mean? And so I'm not explaining that well, but pain is 100% an output from the brain, and so I think the biggest thing, like with patients, I never say your pain is in your head, like your pain is in your nervous system. And there's something here, whether it be actual legitimate tissue damage or kind of an overprotection. Your brain has concluded that you should, like, it's put pain there for a reason. Maybe that reason is because the tissue actually needs to heal, or maybe the reason is because it doesn't feel safe, in which case maybe we do need to expose. And so that's the art of being a physio, is figuring out when you're in the former situation versus the latter, right?
Totally. And I like how you classified that, like pain just isn't in your brain, but it is in your nervous system. Like I feel like that is so true, because we spend so much time learning about like the difference between either peripheral or central sensitization, right? And the different mechanisms by both. But combining them and just saying that, it's in our periphery, right? It's in the sensor receptors. And it's also in our brain. Like I feel like you can never have one without the other. It's just it would be interesting to see if you didn't quite need. Well, you always going to need the central nervous system to interpret pain.
Yeah, I don't think you can have pain without a brain.
No, amen to that. But I was just thinking, like even you think at the level of like the peripheral nervous system, right? Like, can you have a peripheral nerve, like let's say referred pain from an organ, right? Like you have to cross the spinal cord, right? It's just the pathway won't be complete. But does it have to go up to all of the like the thalamic sensory type processing up in the brain, or can it be dealt with at the level in the spinal cord? And again, this is me thinking way the heck back, but do you remember that, like at the level of that dorsal root ganglion, how you can have the two directional firing, like that orthodromic, antidromic,
orthodromic impulses.
And although that's the central nervous system, the spinal cord is definitely not the brain, right? Like the complexity of nuclei is seriously not the same. But you think like maybe like the spinal cord can interpret pain for us, like, and that's how reflexes work, right? Like
that's how reflexes work. I was just going to say, I mean, we do have those built-in things that we don't have to have any cognitive resources devoted to. They just happen, when our tendons get stretched, and et cetera, right?
So true. Interesting thought. And that kind of...
Yeah, but I mean, man, pain is, like when you talk about all the different sites at which it can be modulated, it gets overwhelming,
So true. It is so true. And you think of the description of the phantom limb pain, right? Like I feel like that is such a nice representation over like nociception does not equal pain. Or like the whole paper cut phenomena, like why does that little bugger hurt so bad?
Yeah. No, hey, 100%, man. It's it's so messy. But the phantom limb pain is a beautiful representation of the fact that when you don't have an arm and your arm hurts, we can pretty well say that it's not related to tissue damage.
So true.
It's strange though, man. It's I just think I've had a few radicular pain patients lately, and the sensations they get in their body, the sensation of ants crawling on their back, or like water trickling, and it's just it's so fascinating the way the brain and the nervous system forms this conception of what's going on in the external world, and nerve pain itself, because it's just such a, maybe we should probably do a whole episode on the complexities of nerve pain. It would be good to kind of look into the literature on it.
Mm-hmm. No, totally.
Yeah. So what else is on your mind here when we think about pain and function? Is there anything that you want to add, like, or like what are we missing?
Um, I think that for people who are listening, I feel like there are some conditions that we've outlined that are really important to just revisit and highlight. That honestly, that the less you focus on pain, the better. And I think that, like you were saying, that maybe that a majority of pathologies, that's a good stance to take, because if you do that, you get them moving and you get this sort of exercise-induced hypoalgesia and you get this increase in function. But I'd love to just talk about the arthritic joint for a little bit. Jake, just spend some time with giving me your experiences, because I'm seeing a lot of like the whole physician fear mongering, bone on bone type of representation clinic right now, and to try to find ways and narratives to, one, undo the damage of the physician by scaring them. And it's really tough, I found, as a physio to tell patients information that it doesn't concur with their family doctor, that is actually true from my perspective. Like, I find that being a very challenging feat. And maybe that's just like the whole white coat phenomenon, right? But do you have any tools that you've been using to, especially with arthritis, like knees and hips? I think those are the two big ones. What do you do?
Well, I mean, the first thing is that I try not to be combative at all in terms of contradicting what the GP has told them. I think that's a really good way to build distrust right off the get-go. But I think the biggest thing, man, is showing them that they're robust through giving them an opportunity to, to do things with their body that they may not have thought was available to them. Like, I don't think telling somebody that, you're not going to hurt your knee by bending it is going to reduce their pain. Like, you need to actually put them in a context, find a regression that's basic enough that they can manage it. Like, as Craig Liebenson says, he's a brilliant chiro. He's like, find the hardest thing they do well, and then show them how robust they are. Because once somebody has kind of taken on board that, like, hurt equals harm, until you show them that they can do things they didn't think they could do, I think you're fighting a losing battle. And we've seen that with the research on pain education. Like, if you, like, just reading pain education pamphlets isn't helpful for patient care. Like, it doesn't help. And initially I was like, when I saw that data, I was like, oh, that's annoying, because I've spent all this time, like, kind of looking into pain science and how to deliver key messages of pain science. But, now that I've had a bit more experience, it totally makes sense, because people learn through like somatic experience with their body. They don't just intellectualize something and then change. Like, does that make sense to you?
Totally true. And you know what? I think the best takeaway from that is, like, don't create that sort of that combat off the hop. Like, don't try to trump, don't try to disprove. Show them. Like, and that's kind of like the art of physio, right? Like, because science says one thing, and you can just go and parade around and talk about the science of arthritis, or how a movement is going to replenish the synovial fluid, which is going to in turn help the cartilage, or whatever the heck you want to talk about. Mm-hmm. But if you just show them that they can do these movements that they're scared of and change that, I feel like that is the impactful lesson to learn, right? And then they're going to go home and move it some more and think, wow, like this guy really knows what he's talking about.
Yeah, and then it depends on the patient. If there's somebody who seems interested in, like, reading research, or there's somebody who's educated and are really either trying to do a deep dive on understanding their own body, I'll send them, like, a paper on the prevalence of asymptomatic pathology in like the knee joint if they have knee pain, and and just show them that, okay, listen, like, this guy isn't just creating his points out of thin air. Like, he's evidence-based, and he has some papers that can back things up. And obviously for the majority of people, they're not interested in that, but, like, I have done that with good effect for a few clients, where you can get into discussion about the evidence, and that's great, but it has to be coupled by demonstrating that they're robust. Yeah, I mean, it's like graded exposure, right? You don't if you're scared of anything, you need to physically expose yourself to it. You can't just think about it and intellectualize it. Yeah.
Oh, so true, so true. Do you ever use the what is it? Is like that pain radar plot as a part of your analysis for treatment plans or for um, like the whole the plot that's like differentiates between like is their pain coming from nociception or from their physiology or from rather like their social aspects or their their central nervous system opposed to the peripheral nervous system and all that kind of jazz.
I try to distinguish between like nociceptive pain, and maybe like more just like sensitization, but I wouldn't say I'm very good at distinguishing between like peripheral versus central sensitization. And I don't have like all the scales and the questionnaires integrated in my practice to be really dialed in on that. But I would say I try to differentiate between neurogenic pain versus somatic referred pain, versus local. Like it's tough, but I think there's limits to how much we can do. What do you do?
It sounds a little bit on the hokey side, but I do it like intuitively. You know what I mean? Like I tried to like paint this picture of this person like from the moment that I see them. And like people will tell you almost like how to treat them just by talking to you. Like
Yeah.
if you just care enough to listen. But like I know there's all these bloody scales like the pain catastrophizing scale that you could give them and score it and then put this plot. But no, I just listen to them and I watch them. And a lot of the
Yeah.
time, like their actions speak louder than their words. You know what I mean? Like, oh, like it's like the whole phenomena. Like my shoulder hurts. I can't bend it this way, that way, but like they can put their coat on just fine and get like perfect internal rotation. They're like, oh yeah, okay.
Yeah.
So you can kind of take a bit of a different approach, but no, I don't. I don't do a
Yeah.
lot of the like the screening measures. And there's one that I do
Yeah. I
use
think
is the patient-specific functional scale, and I think that's pretty cool. But it boils back to function, right? Like it's less to do with pain. It's like
yeah.
from 0 to 10, how how able do you feel to do your tasks? I think that one's pretty good.
Yeah. I'm a huge fan of that one. It's simple. I will say it's funny. Mark Laslett, who's a cluster of Laslett for the SIJ, right? He he does the central sensitization inventory on all of his back pain patients, and then if they score above a certain threshold, he just doesn't treat them. He just sends them down the road to some. He's like, I'm not a pain therapist.
Mm.
I'm a diagnostician. If you have a pathology, I can identify. I'm going to triage you into But he's like, I don't deal with chronic kind of centrally sensitized people. It's kind of interesting. So over time, I'm sure that we'll kind of refine our approach on these things.
Totally true. And I think like with the aging population too, I feel like function is more important than ever. I feel it's inevitable. We're as we get older, we're just going to experience more and more pain. So
Yeah.
to try to find tools to just continue doing the things that we love doing, and to negotiate with our aging bodies, I think that's a good relationship to form.
Yeah, man. And honestly, like inactivity right now is an epidemic. And yeah, when you think of the rates of obesity and like all of these kind of preventable diseases, like type 2 diabetes and just things that like we know that we can impact to some degree through movement, independent of the whole conversation about what mediates recovery of their condition. The secondary side effects of focusing on function, like when you think of the increases in bone density and preventing muscle atrophy, which we know is so important for metabolic health, and like we can turn around somebody's life and reduce their risk of suffering so many diseases later in life by giving them permission to move, right? And like I think that's like you can get so in the weeds on pain this and pain that, but like yeah, just having that bigger picture perspective where it's more about like just giving people permission to be physically active, like meet the physical activity guidelines, and you might be saving them from heart disease in 30 years, whereas if you kind of had this nocibic messaging that running's bad for your knees, like you never know the path you could be sending them down. right?
That's so true. So true. And given the fact, I think that then they find that recreational running's preventative against knee arthritis.
Yeah.
So
Yeah.
yeah, it's fascinating, man. It is very fascinating, and I wonder, like, are we getting to a place with science and research that we're understanding pain more or less, and it's tough to say, hey, because I think I think Descartes had it figured out pretty simplistically back in the day. It just seems
Yeah.
it seems like it's getting more and more complicated, but it still doesn't solve the problem that every day you still have to get up and you have to, like you said, do your activities of daily life regardless. Um, and I honestly don't think there's anything more painful than watching somebody else have the life that you want to have because you're too scared to move. Um,
Hmm.
and I think that sort of, we're saying, like, emotional pain, that sort of like psychological and emotional pain might far outweigh this sort of physical pain that you have because you have arthritis in your knee. And I see that I see
Yeah.
that too much. Like people coming in to say, like, oh, like I just sold my golf clubs or I just sold my kayak, and like it's the one thing that I really love doing. I have this one guy. He lives on a golf course and he just tortures himself. He said, I had to get rid of my golf clubs because, like, my low back hurts every time I play 9 holes, and he just sits there now in his kitchen and looks out on the third green, and it's just horrible, right? Because
Yeah.
why not just
Yeah. It's heartbreaking. Yeah.
totally.
Yeah. Yeah. Because you just think of all the points that, like, what led him down that path, right? And
Hmm.
how I guess that's maybe a good way to, like, kind of wrap it up, is like how, like, every patient interaction we have, we can either be making people in our society more robust and resilient and bringing them closer to their goals and living the life that they want to live, or we can be bringing them further away from that. And I don't think that your business model should be a reason to you know to avoid focusing on function. Like, I think that's, I mean, the ethical way to treat is to just get people back to doing what they love. And yeah, so
Totally.
I think that's probably a good way to kind of
Yeah,
wrap it up.
finish off. Do you have any resources you think for people who want to learn more about pain, where they can go and?
I think Lorimer Mosley's work, which I've mentioned a couple times, is excellent. Same with Peter O'Sullivan's work out of Australia, cognitive functional therapy. Um, they have some great stuff, and he has some really fantastic papers, which kind of goes into the whole overprotection concept. Those guys are really on top of the game and are constantly putting out, like, fantastic research. Yeah, those would be the two names that come to mind. Obviously, like, the course that I can't recommend enough would be Reconciling Biomechanics with Pain Science, from Greg Lehman, which was just a fantastic resource to learn more about pain, and he kind of goes into a lot of these decisions, like expose into a painful movement versus avoid away from it. Um, yeah, those would be the three names that I think would be worth looking into for people.
No.
How about you?
Um, I think that there, for patients and people who experience a lot of, even chronic pain, things like that. There's I think it was through UVic, kind of where we did our undergrad, that I think it's called liveplanb.ca, I think. And there's one more, is that's selfmanagementbc.ca. Those are two really cool online resources for just people who are experiencing a lot of pain.
Nice.
Yeah. And then, like you said, like I totally echo the Greg Lehman. Didn't he have a part in that pain management guidebook?
Yeah.
A couple of other ones
Yeah.
that are really, really good reads for clinicians, that's for sure. And I would advise one thing is, I remember this when I was kind of looking at what it means to be like somebody who is an expert in pain and things like that. I never quite understood it. I think that, especially in private practice, we need to be cautious over where we send patients to, and just because somebody says they're an expert in the field doesn't actually make them that. Regulation, I think, is a problem with people who are offering, expertise or specialties in chronic pain, opposed to just any other kind of ordinary PT. So I don't know if there's any
Hmm.
way of fact checking clinicians, but there's a lot of people offering a lot of different type of specialized physical therapy that I don't know how special it is. Um,
Yeah.
so just be mindful.
Yeah, I mean, I would just caution anybody who's going to a physio clinic that if in the first few sessions you haven't gotten off your back of the treatment table and you haven't done anything more than, you know, clamshells and manual therapy, like, you know, you might want to look into a different physio clinic, you know?
It's so true. It's so true. You know,
it should be progressive. A lot of it is just very simple. It's like progressively overload people. You don't make people more robust by having them lay on a table.
Amen to that. You know, and I think the last point here is like I have this this sort of like almost like a 3 visits rule. You know, like if it hasn't gone somewhere within 3 visits, like am I actually doing my job? You know, or is it? So I don't know. It's different for every person, I'm sure.
Yeah. Case by case.
Anyway, my friend, we'll leave it at that.
Yeah, we'll leave it at that. Okay, you take care, Brando. Good talking to you.
You as well. Take care.
Thank you so much for listening to the Paradox PT podcast. If you have any comments or feedback, the best way to get in touch with us is on Instagram. Brandon can be found at Pacific Edge Physio, and I can be found at leo.physio. We'd also really appreciate it if you gave us a follow and a like on whatever podcast app you use so you can get notified about future episodes as we release them. Once again, thank you so much for listening, and we'll see you next time.